Next speaker is Dr. Michael Schweitz. Mike is Chief of the Division of Rheumatology at Good Samaritan Medical Center in West Palm Beach. He's also President of CSRO, the Coalition of State Rheumatology Organizations, and over the years now, we've been having talks from CSRO to get us updated on the socioeconomics of rheumatology. Mike received his bachelor's degree, medical degree at George Washington. He was also there as an intern, resident, and fellow. He's been chairman of the Professional Advisory Board of the Southeast Florida chapter of the Lupus Foundation. He's president of the Rheumatic Disease Advocacy Council, and he's president of the Coalition of State Rheumatology Organizations. He's one of America's top physicians. And he's going to talk on healthcare reform, impact on patients and physicians.
Just as a little background, I got involved in advocacy in 2003 when we formed the CSRO. I spent a fair amount of time in Washington dealing with the legislative process, dealing with lawmakers, well, mostly legislative aides, but some legislators. And my conclusion from those 8 years is that the notion that comparing making laws to making sausage is an insult to sausage. But let's talk about what we're here to. Where is the, how do we advance this? Oh, here we are. What we're here to talk about, which is, Healthcare Reform Act, and you're all aware of the history of how this came about. It was certainly central to the election campaign of President Obama. He had a lot of political capital tied up in it. He had a fairly short window of a majority in both the House and the Senate, and he took advantage in pushing through the agenda to change the healthcare system. This actually came about from three tracks. One, the idea to expand coverage to the uninsured. Two, to curb the growth in healthcare spending. And three, to change the payment mechanism for physicians, because there's this growing idea in Washington over quite a period of time, and actually has some data to support it, that the government does not feel that there's clear value in how they pay for health care. And there are studies to show that increasing expenditures for health care dollars does not correlate with better outcomes. So we're going to break this down into two parts. One, the impact of the new law on patients, and two, on physicians. We'll spend most of our time on the latter. There's some aspects of the law that are operational now, and these include establishing a high-risk pool for individuals with pre-existing conditions. There's about $5 billion to HHS to administer this. It's basically a premium subsidy program. It can be administered either by state or federal program. There are some conditions to get into the program. You have to be without coverage for 6 months, and you have to have written notification from your plan that you've been canceled. There are other changes that are I think, positive for coverage for patients, and these include, by the way, I'm going to try to present this sort of in the Jack Webb way, just the facts. I'm going to really try not to editorialize. Please don't shoot the messenger, though. Limiting rescissions or limiting cancellations, reducing lifetime caps or eliminating lifetime caps on coverage, eliminating exclusions for patients under 19, and allowing coverage on a family policy until age 26. All these were effective on September 23rd. The last is a little controversial. The bill establishes minimum healthcare expenditure levels for payers. It'll be 80 or 85% depending on the size of the plan. The sticking points are what's included as a healthcare expenditure. The payers want things like broker's fees and some other administrative costs to be included as part of that 80% or 85%. There's negotiations ongoing to finalize those rules. There is donut hole relief. Patients who reach the donut hole in 2010 were given a $250 one-time rebate to cover expenses. The pharmaceutical industry agreed to contribute funds to reduce branded medications by 50% per prescription. And I think there was a little horse trading for some quid pro quos that the notion of negotiating under Part D for better fees was eliminated from the bill. There are incremental increases in federal coverage in the donut hole over the next 9 years. But looking at the funding from pharma, the fee is based on the relative percentage of sales for the particular drug. Totals, it will total at the end of the day about $100 billion. It increases to $4.1 billion in 2018 and then drops back down to 2.8 billion. Those are the things that the bill addresses in the patient world currently. We'll see at the end when I run through the future timeline that there are other pretty significant issues that are going to impact patients. So what about us? Well, we're going to talk about the SGR, which interestingly was not impacted at all in the bill. It was eliminated from the bill because of funding concerns, which is always the concern. DEXA payments, PQRI, CER, the IPAB, which is extremely controversial, misvalued codes, imaging, biosimilars, workforce issues, tort reform, HIT, and we're going to spend a fair amount of time on physician payment programs. So the SGR, the dreaded SGR. The history of the SGR, I'll run through it very briefly. In 1997, in the Balanced Budget Act, Congress passed a law that outlined a formula that basically governed physician payments. And the physician payment came as one number in a pie. And that pie was then addressed by the physician community and how to divvy up that pie, essentially. But so everything you read about the SGR and what it directs is that total number in the pie. That pie, that number, is tied to, based on the legislation in 1997, is tied to the GDP and a number of other factors that we absolutely have no control over. And it says basically if certain targets are reached in Medicare spending as it relates to GDP, then it automatically kicks in a reduction in the overall pie. Conversely, if spending is less, there's an increase in what's called an update. Well, needless to say, over the years, the growth of Medicare spending has resulted in continued attacks on this overall payment. It became apparent a number of years ago that A, it was really not sustainable to keep cutting physician payments, and B, it was totally unfair. And this was embraced by pretty much everybody in Washington. I don't think I've ever talked to a legislator who didn't agree that the SGR was an unfair, untenable program and formula. The problem is fixing it. So we've developed essentially a kick the can down the road program over the last 10 years to try to fix it with a Band-Aid. And that's basically what's happened. I'm sure most of you can figure out that Washington is pretty much a crisis action organization. And nothing really happens until it has to. And this is clearly shown in how they deal with the SGR. And if you look at the history of SGR fixes, they seem to always occur in the second or third week in December, when the cut is imminent. This is what happens when they fix the cut. They pass a law that fixes the reduction. Let's say the reduction is going to be 3%. They will fix a law and sometimes use recommendations from MedPAC, which is the Medicare Payment Advisory Commission, that says, don't cut it, give physicians a 1% update. And they may give us a 1% update. That happened 2 or 3 times. But usually they'll make it neutral. Well, when they make it neutral, it doesn't fix the formula. So the 3% adds on. So at the end of 2010, we were scheduled, it had accumulated to about a 23% cut. And they fixed it in December, they fixed it this year for 1 year. Sometimes they fix it for 3 months and then